Thank you very much. Good morning, everybody, and many thanks for inviting me to take part in this symposium. Thanks for the introductions. So this is a little different, but what I want to do is try and get across that sometimes what we think is supportive care is actually changing the outcome of the underlying disease in our patients. And the notion of bone protection, I think, is one such example, which certainly recent data would suggest that is really quite important in modifying the metastatic process. So what I'm going to do is talk about very briefly the use of bone protection in its classic sense, i.e. to prevent cancer treatment-induced bone loss, and how we integrate that into management strategies for early disease, but then spend most of the time talking about how metastasis happens and how manipulation of the bone microenvironment by bone-targeted drugs can influence the outcome for our patients, certainly in breast cancer and potentially in other diseases, and bring that all together with a recent very large meta-analysis that has been presented but is not yet fully published. So when we think about the use of bone-targeted treatments, there are three potential areas where we may consider them. On the right is the classic area for the use of bone-targeted treatments, which I guess everybody in this room is familiar with. This is where bisphosphonates were developed to treat hypocalcemia and to prevent skeletal morbidity. And you all know that they have transformed the quality of life and skeletal morbidity in our patients over the last 20 years or so. And they've gradually got a little bit better, and we've had new molecules like denosumab introduced, which have improved the efficacy somewhat further. But having said that, to the best of our knowledge, giving a bone-targeted therapy in advanced cancer does not influence survival. It influences quality, but doesn't influence quantity of survival. At the other extreme of the oncology spectrum is the use of these drugs to maintain good bone health. This is increasingly important as our patients live longer, whether they have breast cancer, prostate cancer, lymphoma, whatever. Many of our drugs have adverse effects on the skeleton, and it's increasingly important to recognize that and manage it appropriately. And then there's the possibility that there's a link between these two uses of bisphosphonates and other bone-targeted agents, that they might actually manipulate the bone microenvironment in a favorable way. But let's start with the classic use of bisphosphonates in early disease to prevent bone loss. So this is just to remind you of how bone mineral density increases during growth and early adult life, reaches a peak in our 30s, and then declines as we age, with the well-known accelerated decline in women around the time of the menopause. And of course, if that change in bone mass is profound, then it leads to the condition we label as osteoporosis and the increased risk for fractures in later life. Now, in cancer, on top of the age-related changes, we have the effects of both the underlying cancer, which is difficult to define, but there are data to suggest that cytokines and growth factors produced by the cancer may have adverse effects on the normal skeleton, even in the absence of metastases. And then, indisputably, the effect of many of our cancer treatments on bone health, which leads to accelerated bone loss. And the reason for this is multifactorial, but the primary reason is that many of our treatments that we apply, both in breast and prostate cancer, affect bone by reducing the levels of bioavailable estradiol. And this slide shows the expected bioavailable estradiol, firstly in young premenopausal women, in postmenopausal women, men, and on either androgen deprivation therapy or aromatase inhibitor therapy. And there is a threshold of estradiol that is required to maintain normal bone health. Whether you're a man or a woman, estradiol is probably the most important reproductive hormone for bone health purposes. And you can see that with both ADT and aromatase inhibitor therapy, bioavailable estradiol levels are well below the threshold required for bone health. And so it's not surprising that if you measure changes in bone mineral density in your cancer patients, you will see a much more rapid loss of bone while patients are taking these noxious substances. This slide illustrates the average bone loss in normal aging, both for men and for women on the left, and then the average bone loss per year associated with different treatments. I have to say these are average bone losses in the first year of therapy, which is almost always the most extreme change. But nevertheless, overall, our therapies are probably accelerating bone loss by a factor of 2 to 4. And here's just one example of what happens to patients receiving therapies that profoundly affect estradiol. This is the study from Michael Ganant in early breast cancer, where patients were receiving ovarian suppression therapy plus either tamoxifen or anastrozole. And then the other half of the patients had, in addition to endocrine therapy, bone protection with zoledronic acid. What I really want to make clear to you here is that the profound change in bone mineral density over 3 years that occurs in the absence of bone protection, even in the presence of an agent like tamoxifen, which we classically think of, at least in postmenopausal women, as being bone protective. But even in the presence of tamoxifen, the effect of ovarian suppression on bone loss is really quite profound. And then if you give ovarian suppression therapy plus an aromatase inhibitor, as in this bottom curve, you see loss of up to around 15% of bone mineral density over a 3-year period. There is some recovery when you stop therapy, but you probably never get the quality of bone again that you had before you started. What you can also see from this slide is that if you give bone protection, as with the top 2 curves, in this case 6-monthly zoledronic acid, you prevent the bone loss. So over the recent years, a number of groups have got together to address the management of bone loss, particularly in breast cancer. There are some guidelines in prostate cancer, but they're less well defined. But in breast cancer, we have a number of guidelines, the most recent iteration of which was published in the ESMO guidelines a few months ago, work that I was involved with Matti Apro and Jean-Jacques Baudy and others. And this is just an algorithm that is suggested for the management of bone loss during treatment, which certainly applies to breast cancer, but may also apply in prostate cancer. And it's a risk-adapted strategy, and it's a risk that's based not just on bone mineral density, but also on the classic risk factors for fracture, which have been defined by our osteoporosis colleagues. And you can read those risk factors for yourself in this middle panel. And they are at least as important as bone mineral density in determining fracture risk. So if you don't have risk factors and you have good bone mineral density, you can just observe. But if you have risk factors with or without low bone mineral density, then you probably should be intervening with not only lifestyle changes, but also bone-targeted therapy. So in the context of early disease, the current recommendation would be to follow the algorithms like ESMO's for selecting patients for bone-targeted therapy. But what I want to now do is to go into what happens to the underlying disease if you do apply a bone-targeted therapy. And if I can convince you that this treatment improves outcome, then maybe this algorithm isn't particularly relevant, that whole groups of patients should be receiving adjuvant bisphosphonates, not just for their bone protection benefits, but also for their anti-cancer effects. And this is based on the fact that the spread of cancer is not just down to the biology of the primary tumor. It's influenced profoundly by the microenvironment that the cancer cell finds itself in, both within the primary tumor, within the primary organ, and certainly within the distant metastatic site. And it's very complex with many different cell types, many different factors, and many other properties, including physical properties, which interact between the microenvironment and the cancer cells. And all of these properties can interact simultaneously in time and space. So perhaps it's not surprising that if you can manipulate the environment, you can have a beneficial and theoretically an adverse effect on the spread of our underlying cancer. This is a schematic diagram of the hematopoietic stem cell niche, which is a concept which has evolved over recent years as being the likely recipient for disseminated tumor cells prior to the development of overt metastases. So this is a interaction between normal cell types within the bone marrow microenvironment that is there primarily to allow hematopoietic stem cells to survive long periods and await their requirement to produce progenitor cells. But this niche, whether it's a concept or an actual physical entity, is something that we believe cancer cells have the ability to hijack and utilize in the metastatic process. And that's shown here, that normally the hematopoietic stem cell is anchored into this niche, which is associated with osteoblasts by the interaction of CXCR4 and CXCL12. Now, cancer cells can also express those chemokines, and so they may have the ability to displace hematopoietic stem cells and anchor themselves into this niche, where they become less sensitive to standard anti-cancer drugs. And so if we could change that, if we could remobilize them, then that may make them more sensitive again to our underlying agents. I want to just show you one animal experiment which we've conducted recently, which I think illustrates how profound a change in bone cell function can be for metastasis. Now, this is in mice, but it's an illustration of a phenomenon that may well be relevant in patients. What we've done with these mice is we have increased osteoblast activity by giving a very short treatment with parathyroid hormone, just 5 days. And one of the things that parathyroid hormone does is it increases osteoblast activity. So in these mice, we give PTH for 5 days, and you can see in this panel that leads to a short-term, just a few days, increase in osteoblast activity. And at the end of the PTH, we inject some tumor cells. And so what we're looking at is what happens to those tumor cells in either control mice that have normal bone turnover or PTH-treated mice that have increased osteoblast activity. And what we see is that those animals that have received this very short exposure to PTH get more skeletal tumors. And there's a gradual rise in the incidence of bone tumors throughout the course of the experiment, which only goes out to 6 weeks for animal husbandry reasons. And the corollary of this is that if you look at circulating tumor cells in the mice, which we do at the end of the experiment, we sacrifice the mice and we take the blood and we look for circulating tumor cells, you find fewer circulating tumor cells in the mice that have been treated with PTH, as though the cells have been sucked out of the circulation into the bone marrow microenvironment where they form the tumors. So if this translates into the patient setting, it's not surprising that changes in bone cell function could influence disease outcomes for our patients. So coming back to the pathophysiology of bone metastases, tumor cells colonize into the bone microenvironment. They colonize before we've made the diagnosis. Those patients destined to relapse have their disseminated tumor cells at diagnosis. We just don't recognize them or cannot measure them. And then over a period of typically years, those cells wake up from their dormant state, leave the hematopoietic stem cell niche, become active, proliferate, and form metastases. Now, normally, when we give bone-targeted agents, we're talking about treating this end of the spectrum and trying to, if you like, what we would say, close the stable door after the horse has bolted. But when we use them here, we have this profound effect on bone cell function. So I want to share with you now the clinical data that suggests that this is worthwhile in our patients and is clinically relevant. Firstly, some translational work. This is a fairly complex slide, but the message is simple, that there are many experiments now that have been done that have shown that if you measure the number of disseminated tumor cells in the bone marrow in patients with early breast cancer, that the number of disseminated tumor cells is less, or they're more difficult to find, or the numbers reduce if you give those women a bisphosphonate, in this case, zoledronic acid. So that is suggesting that a bisphosphonate is either destroying the disseminated tumor cells in the bone marrow or making them go somewhere else. But the likelihood is that it's destroying them. And this has nothing to do with the underlying cancer therapy. This is in the absence of other anti-cancer treatments. Now, in terms of treating disease that we can't see in the classic adjuvant setting, the idea of giving adjuvant bisphosphonates is by no means new. And these three investigators, Trevor Powles, Ingo Deal, and Tina Sato, all ran randomized clinical trials in the 1990s to look at the role of, in this case, oral clodronate to prevent metastasis. And certainly Ingo Deal and Trevor Powles showed important beneficial effects with fewer metastases and better survival. But it was just too hard a concept, I think, for most oncologists to grasp that this was a real phenomenon. And it was really only when this gentleman, Michael Ganant, presented the outcome, the disease outcome data from the ABCSG12 study at ASCO in, I think, 2008, that there was a sort of realization that there might be something in this. And what Michael's study showed was in a very specific population of premenopausal women, the use of the bisphosphonate that he'd given to prevent the bone loss was also improving disease outcomes. And this is the most recent update, which is now accepted and in press with Annals of Oncology, showing that at 7 years, this improvement in disease-free survival is maintained. However, things became a little bit more complex when this study, which I had the pleasure of leading, was presented and then published, which also addressed the role of adjuvant bisphosphonates, but in a much more diffuse population of patients, young and old, ER positive and ER negative. And indeed, this study, at least in an intention to treat analysis, showed no effect on disease outcomes. So at the first sight, a very different and a disappointing result from the one that Michael Ganant had shown. We were able to show an effect on bone metastasis, but that was not powerful enough to drive an overall effect on disease-free and overall survival. But what we also showed was that in postmenopausal women, there did appear to be a benefit of this treatment, and it was being diluted by all the younger patients that we had in our diffuse entry criteria for the AZURE trial. Now, of course, this was a subgroup analysis, and although it was pre-planned, it was not sufficient to change clinical practice, but it generated an important hypothesis. And the hypothesis was that these bone-targeted agents reduce metastases, particularly in bone, in women who have low levels of reproductive hormones. So that's either women who are postmenopausal or women like in Michael Ganant's study who are receiving ovarian suppression therapy. And we also raised the notion that there might actually be some adverse effects in premenopausal women. So to address this, we've conducted a very large, robust individual patient meta-analysis with the Oxford Early Breast Cancer Clinical Trials Group. And these are the data that are presented but not yet published. We expect to submit these for publication before the end of the year. This is a summary of the data received. You don't need to worry about the numbers, but if you look at the bottom line, you can see that there are a lot of data out there. There are 36 randomized trials, over 20,000 women, and we have individual patient data from about 90% of these women who took part in randomized trials. So we have a very large data set with no major studies missing from our analysis. We may get the others as well in due course, but at the moment we have 90% and 19,000 patients. And what the Oxford group do is that they perform a robust individual patient meta-analysis, and then they present the data in this format where we look at outcomes over 10 years. So all these plots look the same. They all go out to 10 years. They show recurrence or survival. They give you the numbers of patients assessed, and they look at the difference between bisphosphonate-treated and non-bisphosphonate-treated patients. And just like the ASIA trial, if you look at all women, there's not much to see in favor of giving a bisphosphonate. A 1% difference at 10 years, I would say, is not particularly exciting. There is an effect on bone recurrence, as you can see on the left. It's small, but it's significant. But it's not a subset finding, it's a general finding. But what the meta-analysis has done is confirm the hypothesis that there is something going on in postmenopausal women. And postmenopausal women have, of course, different bone turnover to premenopausal women. If you look at bone recurrence, there's nothing happening in premenopausal women on the left, but a clear, highly significant benefit in postmenopausal women, as shown on the right. Now, menopause is often quite difficult to define, so we've looked at age, and this is a forest plot for the effect on bone recurrence by age. Absolutely nothing in women under 45, a very big effect in women over 55, who are almost always, of course, postmenopausal. And in those women in the 45 to 55 age range, you can see that those that said they were premenopausal gain little or no benefit, and those that said they were postmenopausal do gain benefit. So the age analysis supports the menopause analysis. For adjuvant therapy to be introduced, we ideally like to see an effect on mortality. And perhaps surprisingly, that effect on recurrence in bone does appear to be driving a very important effect on overall survival in postmenopausal women. So again, we're looking at breast cancer mortality in premenopausal women on the left and postmenopausal women on the right. Absolutely nothing happening in the premenopausal population. But for postmenopausal women, there's an absolute benefit of 3% at 10 years, which is clearly statistically significant, and I would suggest is clinically significant. I'm going to brush over this very quickly, but this is an attempt to try and say which bisphosphonate, how much, and how long should you give? And the answer is it probably doesn't matter which bisphosphonate you give, it probably doesn't matter which dose you use, and we can't at the moment see any difference between 2 years and 5 years. So you may not need very much. It's very likely the use of these drugs very early on in the adjuvant setting that is of most importance. Is this mortality benefit clinically worthwhile? Well, I would suggest it is. This is the 10-year risk reduction that we see with treatments that we apply every day of the week in oncology settings. You'll be familiar, those of you who treat breast cancer, with all of these outcomes. And at the bottom is the impact of bisphosphonates on 10-year mortality in postmenopausal women. A 17% reduction in the risk of dying at 10 years, which in the UK alone would equate to 1,000 lives per year. Why is this happening? Well, I've already said that the bone physiology is different in postmenopausal women to premenopausal women. Estrogen disappears and other reproductive hormones become important. And so to finish, I just want to come back in the sort of reverse translation to the laboratory and try and show you that we can reproduce what I've just shown you in patients in mice. So in this experiment, we have treated mice either with or without a bisphosphonate, and either with or without an oophorectomy. So we have development of metastases in bone in black and outside bone in white, in control animals, in animals that just have a sham operation but don't have their ovaries taken out, and in the oophorectomized mice. And you can see that oophorectomy increases tumors, just like giving PTH did. So increased growth of disseminated tumor cells following oophorectomy. Now when we look at the effect of the bisphosphonate, we see these are the sham control animals. So this is the baseline incidence of metastases. The animals that didn't have the oophorectomy and given bisphosphonate, it did nothing, just like in premenopausal women. This is the increased bone metastases in the oophorectomized mice, and this is the inhibition of those metastases in the oophorectomized mice with the addition of the bisphosphonate, with levels that are less than the control animals. So a preclinical confirmation, if you like, of what appears to be happening in the patients. So I'm going to finish there with just some conclusions. Clearly, cancer treatment-induced bone loss is important, and if we hadn't been addressing that, we might never really have started to see some of these effects on overall disease outcomes. But what we've learned over the last 10 years is the bone marrow microenvironment is central to tumor dormancy and metastasis. And I hope I've convinced you that in postmenopausal women, these drugs, whether it's clodronate, whether it's zoledronic acid, it probably doesn't matter too much, are able to reduce bone metastasis and improve overall survival, and I think should be considered as part of our adjuvant treatment programs in the future. Thank you very much.
Thank you very much for this excellent presentation. Est-ce qu'il y a des questions dans la salle par rapport à cette présentation remarquable? No? Okay. So I just have a question for you. Of course, we are waiting for the final publication of this meta-analysis, but are these results for menopausal women independent of chemotherapy? So, because we are waiting for the subgroups of patients in your meta-analysis, you know. Donc, je demande si effectivement ces résultats observés sont observés dans tous les groupes de patientes ménopausées traitées en adjuvant ou uniquement chez celles qui n'avaient pas reçu de chimiothérapie? This is a real question for us.
Yeah, that's an important question. And in the meta-analysis, about 60% of the women had chemotherapy and 40% didn't. And the impact is exactly the same, irrespective of whether chemotherapy was given. We've also looked at estrogen receptor status and grade of the primary tumor, and that doesn't seem to influence the disease outcome. So this intervention seems to be as powerful in ER-negative breast cancer as it is on ER-positive. Again, making the point that this is not an effect on the tumor cell itself, it's an effect on the microenvironment and the ability of cells to survive in this dormant state.
Des questions? Oui.
Yeah, I mean, we don't have any randomized data in breast cancer. Those trials will report in due course. I think it's quite likely that if this is just an inhibition of osteoblast and activity and bone turnover, that denosumab will be active. And we have a clue for that as well from the randomized study done in prostate cancer, where denosumab was given to men with rising PSAs, but before overt metastases. And in that setting, denosumab was able to delay the time to bone metastasis, so it met its primary endpoint. It didn't get approval for reasons of that there was quite a lot of osteonecrosis of the jaw in that study, and it was felt that the benefits did not outweigh the risks, particularly as there wasn't a survival advantage in that study. So my guess is that denosumab will work, but I think it's unlikely that it'll be any better than a bisphosphonate. Dick.
Rob, if this effect is on survival is correct in postmenopausal women with breast cancer, and you mentioned just now that approximately 60% of these women were treated with chemotherapy and had similar effects. What about other malignancies? Now, if you have a 15 to 20% survival, we're talking about a lot of people receiving adjuvant therapy. Why wouldn't this have an effect on, say, women with colon cancer who receive adjuvant therapy or lymphoma or some other diseases?
Well, I think it would probably only be relevant for those tumors where the bone microenvironment is of critical importance. And I guess in colorectal cancer, that's probably not the case. There are studies going on in lung cancer. There are studies still ongoing in prostate cancer. I think many of those studies have been underpowered. You can see that to actually try and work this out has required far more patients than is ever possible in a single trial. And I think it's only now that we understand the subgroup of patients that we can perhaps design appropriate randomized trials. So it may be that you have to have the same hormonal milieu for other cancers, but we just don't know that at the moment. So I think it's worth testing. There are trials going on, as I say, in lung cancer with denosumab as well as bisphosphonates, and it's possible. Of course, in many other cancers, mortality is less likely to be driven by bone metastasis. If it's going to work, it was always most likely to work in breast and prostate cancer, where bone is the dominant cause of death.
Okay, thank you very much, Mr. Coleman.